Hi, I'm Dan Bockmann. This is my channel. Thanks for dropping by. As a military physician assistant, I see an awful lot of MSK injuries, musculoskeletal injuries. Acute, chronic, atraumatic, traumatic, and today I want to discuss what I consider to be the gold standard in MSK injury treatment and prevention. And as my guide, I'm going to be using my brother Dan Bockmann, a longtime Austin Chiropractor's MSK white paper that he wrote several years ago. Now, he was known to his patients as Dr. Dan, and diagnosed with stage 4 colon cancer, died around this time last year. But before he did, he left us with a lot of insightful, humane, encouraging treatment videos and videos about his cancer journey, but also this white paper, which he considered to be the culmination of his life's work. I shared it with my colleagues a couple years ago, and he wanted me to share it with the world because he wanted everyone to benefit from his life and work. Now, this white paper is an overview. It's almost a story, in a way, of how he arrived at his treatment philosophy and techniques. And he emphasizes that while his philosophy and techniques work and are based on his decades of experience, he doesn't know the exact mechanisms. If the story is followed, though, he says, the patient gets the desired results. He calls it directionally accurate. He also emphasizes that he was sort of proud about this. He cites zero research. There's not a lot of good research, as it turns out, to cite, but he cites zero research. Although he's done his own trial and error over the decades, he was able to see each patient for an average of 1.8 visits before releasing them at 80% better into the wild. And he was well aware that this treatment model, this business model, was not exactly stable. And so he depended on lots of good results and lots of patient word of mouth referrals in order to grow his business. And I think he succeeded brilliantly. So without further ado, let's start the white paper, which he entitled Rethinking MSK Evaluation and Treatment. I'm going to read it to you direct, because if I summarize it in my own words, we're going to lose some of Dan's voice, which I think is really nice to hear coming through his writing. And I think it's well written, it's very direct, and we'll see how it goes. Okay, so this is page 1. Basically, he calls it the information gap. He says, when I graduated from chiropractic school in December 2000 and started my first job as an associate doctor at a group practice in Houston, I quickly found myself out of my depth. Even though I did well in school, I began to realize that most of what I'd learned didn't prepare me for actually treating patients. Basically, I felt smart, but not capable. Our education was heavy on health sciences, imaging, and diagnosis, but very vague on what treatments actually work for various conditions. And while we did take physical medicine and rehabilitation courses, the actual treatments we learned were, for lack of a better word, weak. Electrotherapy, heat and ice, therapeutic ultrasound, spinal extremity manipulation, traction, vibratory massage, etc. All of these are generally considered to be low-value treatments by the literature. Also, there were no clear guidelines for how to craft a treatment plan, to progress a patient through it, assess progress, identify when to modify, determine when to release a patient from care, and teach them how to prevent recurrences. So when I was treating a patient of my own, it felt like I was literally guessing how best to treat them, guessing which exercises they might need, guessing when progressions should happen, guessing when they might need them, guessing which stretches they needed, guessing how long to hold a stretch and how often, etc. I felt like a fraud. I had 8 years of school, a license, and the title doctor, but internally I knew I was clueless when it came to why we hurt, how to reduce pain, and how to keep it from coming back. And yet, I had to craft treatment plans, explain the rationale to patients, and make all these decisions. I just felt like an imposter every time I did it. It was a miserable way to practice, and I continually doubted my decision to pursue this career. So, I decided to fill in my information gaps. Surely, I thought, there are much smarter people than me, experts in the musculoskeletal field, who have answers. So I read textbooks, studied research voraciously, followed the foremost MSK leaders and teachers both in the chiropractic and physiotherapy world. I attended seminars, watched lectures by the most famous names in the business, listened to podcasts, and attended hands-on workshops. I was determined to be evidence-based in all aspects of my practice, using only the very best approaches for evaluation and treatment, those supported strongly by the literature. But the more I learned, the more disappointed I became. It began to appear as if no one had the answers. In fact, most of what I found in research and from all the experts was what not to do. This treatment performed poorly when compared to this other treatment, which also performed poorly. Also, the quality of the individual studies was consistently poor to very poor, which made me wonder how much I should be trusting the few conclusions they arrived at. And no research showed strong evidence that a particular treatment approach actually worked, as in, it consistently helped the patients get better. The best I could find was doing this is slightly better than doing nothing at all. Not a strong endorsement of the treatment or of our understanding of the problem that required the treatment in the first place. I was more disheartened. It appeared the best docs and researchers in the business were in the same boat as me. And our best option was basically to let nature resolve our patients' issues and try not to get in the way by making things worse. In fact, one prominent pain researcher explained to me the best possible approach for low back pain should be 1. Literally any treatment. 2. That requires few sessions. 3. And doesn't make the patient worse. This is what was considered to be the gold standard of care for low back pain as supported by research. Not very confidence inspiring. In my despair and disillusionment, I wondered if I could come up with a better treatment approach myself. The problem, of course, is that I have no background in research or academics, so I had no idea where to start. So I began looking for patterns with my patients. For example, I started noticing that most of my patients with lower back pain had tight hamstrings. Hamstrings that felt tight to the patient and, more importantly, limited their range of motion, ROM, when compared to other patients without LBP, low back pain. I wondered if tight hamstrings might be contributory to the pain. My question was, if tight hamstrings are a contributor to LBP, does restoring normal range of motion relieve back pain? To test the hypothesis, I prescribed hamstring stretches to see if they gained any significant improvement. But even this was difficult as there were no widely agreed upon guidelines for stretches that he could find. For example, stretches have variables that can influence effectiveness of the stretch. The 3 elements of a stretch: frequency, intensity, duration. And to test my theory, I'd need to get each of these elements right if we were going to see net range of motion improvements daily. So I tested different frequencies, 1 time a day, 3 times a week. I tested different intensities, easy, moderate, aggressive. And I tested different durations, 20 seconds, a minute, 5 minutes. My initial goal was to find a stretch prescription that would gain range of motion every day you do it and give a net improvement in range of motion over time. Essentially, this enables you to gain ground and keep it. Too often I hear patients complain that they stretch regularly and feel a bit looser that day, but the next day they're just as tight as they were before. So I found that we got the quickest range of motion improvements if they 1. Stretched 2-3 times a day, maintained a barely tolerable stretch, and 3. Held it for 1 to 2 minutes. I found these rules work consistently to regain range of motion in my patient population and seem to apply equally well to all patients, young, older, fit, sedentary, acute, chronic, and most importantly, patients found their pain levels dropping the more range of motion they gained, especially if they had big range of motion deficits. There are many more iterations of this process that I'm not including for reasons of brevity, and a few exceptions, but these are the rules I generally follow for stretches. Then I repeated this process with other therapies: exercise, massage, manipulation, lifestyle modification. Over 20 plus years in practice, I've fine-tuned this approach. If I find a different stretch that seems to work more quickly or is easier for the patient to understand and implement, I'll adopt that version. Same for other interventions. This process also eliminates weaker treatment tools since they fail in comparison to the stronger tools. What I've ended up with is a simple general approach to MSK evaluation and treatment that works for most patients, not all, and is easily understood and implemented. And virtually all treatments can be performed by the patient on their own with little to no equipment needed. Obviously, this reduces the patient's dependence on me, their provider, and empowers them to regain and maintain their health on their own. Now here's an example of my general approach to MSK conditions for both spine and extremities. First, loosen tight things, strengthen weak things. Following, you'll find an outline of my general approach, along with examples of how I explain the rationale and mechanism of effect for patients. Since it tends to focus on two main elements, I'll refer to this approach as loosening tight things, strengthening weak things. Now, I don't presume to know the actual mechanism of why pain happens, why one therapy might work better than another, or why pain goes away when it does. My explanations to patients are intended to be illustrative only. I want explanations to be directionally accurate, meaning, although the actual mechanism may be different than I describe, if the story is followed, the patient gets the results we both want. To my knowledge, there is no strong existing evidence that supports this approach, and likely plenty of research that refutes parts of it. However, there isn't strong evidence for any approach in the MSK world, and since the gold standard of care apparently says that any treatment delivered in a few visits that doesn't make the patient worse is the best course, this is how I meet that very low standard. You will find zero research reference in this paper. This is not because I believe research to be useless. To the contrary, research is crucial for advancement in science. It's simply because no research has influenced the development of this approach. A snapshot of my practices gives us the following stats over the past 365 days. We had 597 new patients, an average of 1.8 visits per patient, one doctor, one staff, remote. Half of the cases are spine issues, half are extremities, half of cases are athletes, half are normal people. They're 60% acute, 40% chronic, 95% were non-surgical, 5% were post-surgical. There was a cash practice, and he was releasing patients at 80% better, equipped to get the remaining progress on their own, and equipped to not need me again for this issue. Until I find a better approach, this is what I'm using. The premise. The theory of this approach is that there are three main contributors to pain in my patient population. Reduced flexibility, what he calls tight things, reduced strength, what he calls weak things, and lifestyle factors. Clearly, trauma and other factors are possible contributors as well, but the huge majority of my patients have non-traumatic onset of their symptoms, and other contributors are either more rare or contribute to a smaller degree. I still screen for the scary stuff, but as long as we can rule it out, I plug into this approach. Some are big pain contributors, some are smaller. Generally, the bigger the deficit, range of motion, strength, hydration, sleep, the bigger the contributor to why they hurt. If we can identify the biggest contributors and address them first, we should expect an oversized payoff for fixing that problem, since it's a big reason for why they hurt. And if we see significant improvement in the patient's symptoms early, it suggests we're on the right track. Then we can clean up some of the smaller contributors to their pain in a subsequent visit. And if we don't see big improvement in symptoms early, we can change course early and avoid pursuing the wrong treatment path for months. This helps shorten treatment plans by eliminating ineffective care and helps us catch scary problems that may have slipped under the radar initially. Because we expect big results right away, if we don't get them, that catches my attention since it happens relatively rarely. This has been hugely helpful and allowed me to catch various cancers, deep vein thromboses, and other less common but scary conditions. The philosophy of tight things. There are about 360 joints in the human body. Each joint often has multiple ranges of motion it can move through. This approach supposes that if a joint has a full normal range of motion, it is then able to move safely because mobility will allow it. And if that joint's range of motion is limited, it is then being forced to move in a less safe way, which can hurt. For example, if you were to throw a baseball and had full range of motion in your joints, you should be able to throw it with good technique, meaning a more efficient throwing motion that increases ball speed, accuracy, and longevity in your sport. If, let's say, your elbow joint was fused with zero range of motion, efficient throwing form would be impossible and you'd be forced to throw a ball much more awkwardly, which would likely reduce ball speed, accuracy, and your ability to throw that way for very long without hurting yourself. Also, limited range of motion at a joint can mean energy is wasted when that joint is bent, since it takes more effort to bend a tight joint than a looser one. For example, a runner with 10 degrees of hip flexion would struggle to take a long stride due to resistance in the joint. This can shorten stride length and waste energy moving your stiff parts that could have been used to propel you faster. This approach poses that there are three main therapies that loosen tight things: stretches, massage, joint manipulation. Of course, there are more mobility therapies that exist, but these I find to be most effective. The good news about flexibility problems is that once you fix these problems, they don't grow back overnight. Then it just takes occasional touch-ups, nice one, Dan, to your flexibility to maintain the results you gained. Note, I consider flexibility to be the single biggest contributor to MSK problems overall, estimating that they are 80% of why we hurt. These levels of contribution vary, of course, by patient, by condition, and other variables, but by and large, this appears to hold true. Stretching theory. While stretching is often thought of as something everyone should be doing as part of routine body maintenance, like brushing your teeth, I see it differently. I treat stretching as a tool that fixes a specific problem, limited joint range of motion. And once that problem is fixed, you put the tool away like a vacuum cleaner. A vacuum is a tool that cleans the floor. The indication you need a vacuum is if the floor is dirty. The way you tell when you no longer need the vacuum is when the floor is clean. Similarly, I treat stretches as a tool that restores range of motion when lacking and touches up range of motion thereafter for life. Stretches are self-indicating in this way, meaning if you're ever wondering if you need a particular stretch, do the stretch. If range of motion is normal, you don't need it. If range of motion is lacking, it means do the stretch daily until range of motion is normal, then touch up for life. Theoretically, then, if someone had normal range of motion in all their joints, they would never need to stretch. My stretching guidelines. Evaluate for range of motion deficits. Plug in the stretch that addresses each deficit. The bigger the deficit, the better, as it's likely a bigger contributor to their pain and should give a bigger reward when it's resolved. Perform all the stretches 2 to 3 times a day. Hold each stretch for 1 to 2 minutes. Maintain a barely tolerable stretch. Continue until normal range of motion feels easy, then discontinue daily. And then touch up for life by occasionally checking your range of motion. Massage theory. Massage is often thought of as pampering yourself, a therapy that feels good but isn't particularly therapeutic. Many will get a massage while on vacation or a spa trip or receive a massage certificate as a gift. I see it differently. Similar to stretching, I treat massage as a tool that fixes a specific problem, limited joint range of motion. However, while I see stretches as being the most effective tool for increasing overall joint range of motion, I treat massage more as a focused stretch. Stretches are general lengthening of tissue. You can take each end in a different direction, elongating the tissue. Massage, on the other hand, can be directed to a specific part of the body and may clean up sections of tighter tissue that a general stretch couldn't. I define massage as pressure plus movement. By denting or deforming soft tissue, this approach posits that massage can improve mobility and can be applied to areas that a stretch might not help. In this way, I find stretching and massage to be complementary. My indication for massage is tissue tenderness. Clearly, tissue can be tender for a variety of reasons, bruising, etc., but in general, this holds true. Which is useful as tenderness is easy to assess. Therefore, anything that hurts to poke on can benefit from massage, a few exceptions notwithstanding. As a provider, one can pretty easily predict which tissue will be tender, as these areas often feel harder than other tissue that isn't tender. I consider healthy tissue to feel fairly soft and supple when relaxed. If it's dense, or what a patient would call a muscle knot, that area can likely benefit from massage and stretching. Also, with a few notable exceptions, DVT, cancer, etc., massage is completely safe. Patients cannot do harm to themselves applying massage nor receiving one. Massage is intentionally bruising you a little, but bruising isn't meaningful damage and well worth the other benefits. For this reason, patients may feel a little residual soreness in the areas massaged, perhaps overnight, but it should be brief and mild, and typically only happens after the first session and not after future sessions. I consider there to be 2 kinds of massage: the kind you can sleep through and deep tissue massage. And while the comfortable kind can be temporarily helpful, stress relief, relaxation, feels good, deeper massage can give semi-permanent results. Meaning, like stretching, massage can accrue more benefit each time you do it, gaining ground and keeping it. For this reason, I usually recommend deeper massage for patients rather than soft touch. Also, the good news about massage is that if you're performing it on schedule, it should get less painful to do as sessions go by. Once the massage doesn't really hurt to do anymore, you're done. You don't have to do it on schedule. Then just check it periodically and touch up for life. I recommend performing massage every 3 days, not daily. The reason is that this allows you to recover from today's massage before you do the next one. I find that 3 days is adequate recovery time for most patients and allows for the massage to hurt less and less as sessions go by. There's no mystical skill needed for massage. It's simply a matter of finding what hurts to poke on, then beating it up a little. I find massage guns, massage chairs, and vibratory percussive massage to be weaker massage tools, though by all means use them if they feel good. But simple, deep pressure through the tissue appears more effective and can be achieved with basic tools: hands, elbows, rollers, balls. And while I do provide a list of local massage therapists to patients who might benefit, rarely do they need more than a session or two to get their biggest issues resolved. Most patients don't need to see a massage therapist at all, as they can perform the necessary massage themselves. Personally, when working with patients in clinic, I use elbows to apply most of the massage, hands for other areas, and have our patients apply self-massage using a roller, ball, or other tool. My guidelines for massage: evaluate for tenderness and hard tissue. Apply massage to tender areas. Massage tools: hands, elbows, foam roller, softball, etc. 2 to 3 minutes per area is a good dose, what he calls a dose, per glute, per quad, per shoulder. Apply as much pressure as the patient can handle without going rigid from pain. Occasional flinches are fine. Perform every 3 days, not daily, until comfortable to massage all areas. Then touch up for life. Joint manipulation theory. I consider joint manipulation, or spinal manipulative therapy, SMT, to be a mobility tool as well. After all, a joint thrust is really just a short-range stretch. And if stretches can increase range of motion in a hip, for example, couldn't they also increase range of motion in the spine? As with other tools in the mobility category, I treat SMT as a tool that fixes a specific problem. Then I retire that tool once the problem is fixed. My indication for SMT is if spinal range of motion is limited. In this case, the patient may benefit from spinal manipulation therapy. But here's where it differs from stretching and massage. While spinal range of motion is often limited when someone's in pain, it's not always obvious whether that range of motion limitation is coming from the joint itself, like tight ligaments or a capsule, or if it's limited by the muscles and other tissues that attach around that joint. Pain itself can limit range of motion too, even in the absence of a mechanical restriction. Over the years, I've found I rarely need to use this therapy as we achieve our goals for the patient without using SMT. I describe SMT to patients as WD-40 for the spine. If your back is stiff, this may help it move a bit better. SMT is the treatment tool I use least, perhaps with 1 out of 20 plus new patients. Having said that, there are a small percentage of patients who see significant improvements in their symptoms immediately afterward. To me, this suggests that perhaps intrinsic joint stiffness was one of the big contributors to their pain, and restoring some normal movement was one of their bigger needs. Note, I never use the term subluxation to describe the need for SMT. This term already has a definition in medicine, and ascribing it a different definition is unnecessarily confusing to patients, not to mention the fact that a chiropractic subluxation is a made-up condition that cannot be visualized or palpated, and certainly not corrected. Likewise, I never describe SMT as an alignment of the spine, as spinal alignment is generally not a real problem, and SMT certainly never realigns anything. This is one of the things I love about Dan. My guidelines for SMT: Evaluate for spinal active range of motion deficits. If no contraindications, consider spinal manipulation therapy. If range of motion improves after SMT, it may have been helpful. Typically, 1 or 2 sessions of SMT maxes out the benefit of this tool. SMT is not a maintenance tool for the spine. It fixes a specific problem, then gets retired. In short, I see SMT as a specialty tool. It's not needed often, but I'm glad we have it, as it can be quite valuable on occasion. For example, the last spinal adjustment I received was approximately 7 years ago, and I explained to patients that maintaining flexibility with stretching and self-massage reduces the perceived need for SMT. The philosophy of weak things. There's an old saying in the MSK world, you can't go wrong getting strong, and we know it's true because it rhymes. In all seriousness though, exercise offers a host of benefits, improving brain health, managing weight, reducing risk of disease, strengthening bones and muscles, boosting sleep quality, reducing stress, and improving our ability to do everyday activities. In the MSK world, exercise seems to be the only therapy that we all agree is beneficial, even though its support in literature is weak in many cases. It appears to be the strongest of the weak interventions. Even if we don't know an actual mechanism of why exercise helps when it does, we can at least feel confident prescribing it, if only because of the secondary benefits it offers, listed above. But I pose that getting stronger can offer protection against injury as well. Each of our many joints have muscles that attach to them and around them, steering, guiding, securing, and bending our moving parts. In fact, muscles are the only reason we can stand, walk, or jump, but they can protect us too. For example, if I were to stand on a table and step off but go limp in the air, my landing would be horrible. I would collapse on the floor, likely sprain my ankle, bruising my knee, and banging my head. But if I were to step off that same table and engage my muscles to prepare for a landing, I would land lightly, gracefully, and unhurt. In this way, muscles can act as shock absorbers, thus sparing our joints and other tissues from injury. We all know that ligaments help secure our joints, keeping them in a safe relationship as we move, essentially preventing us from falling apart. Well, muscles can do that too. In fact, ligaments are dumb supports, essentially just ropes that tie two bones together. Ligaments can't be taught, can't react to things, and can't stiffen or loosen as needed. Muscles, on the other hand, can adapt. I consider muscles to be smart supports that can be trained, strengthened, taught to react faster and more appropriately, and can work as teams to accomplish movement or secure a joint. This theory suggests that having a stronger, more capable muscular support system should help prevent or lessen injury in a risky situation. Perhaps an injury could be avoided altogether, or the severity of the injury lessened if strong muscular support exists. Also, if a patient has structural damage, a sprain, a partial tear, or herniation, strengthening the muscles around the damaged area could theoretically take workload off the injured tissue, bearing it themselves, and provide the injured region some relative rest during recovery. Having said all this, I find the beneficial effects of supervised exercise to be relatively small compared to the benefits of other interventions in my patient population. Supervised exercise makes up only 10 to 20% of what we do with patients in clinic. The remainder consists of mobility therapies like stretching and massage and lifestyle modification. However, I find the benefits of unsupervised exercise to be enormously helpful. In fact, during our initial visit, I ask each patient which activities they've been forced to stop or modify because of their pain, or activities that they're simply afraid to try as they think it might make their injury worse. This could be formal exercise like tennis, basketball, gym, or simple everyday activities like raking leaves, picking up their child, walking the dog. These things they've cut out of their life because of our activity goals become our activity goals for treatment. These are what we want to restore. Patients love this approach. After all, that's the main reason they came to see us in the first place, to be able to resume the things they want to do and love to do. Most people will put up with a certain amount of pain in their lives, but once their movement world starts shrinking, they're more motivated to get to the bottom of their problem and fix it. In this way, it's easy to set goals for therapy since it will be completely obvious when those goals are achieved. If I couldn't do something before and now I can, I know I'm getting better. Even if the patient wasn't regularly exercising before their injury, they'll always be able to give you some kind of activity goal. I want to be able to wear heels and go dancing, or I need to plant my flower beds and trim the hedges. Sometimes I'll just ask, is there anything that sounded fun to you that you've always wanted to try but never have? Most patients can tell you, well, I've always thought a pickleball looked fun, or something similar. Unsupervised exercise can be more effective simply because it's more likely to get done by the patient. It's often a list of activities that they were doing before they got hurt because they enjoy it or need to do it, so they already know how to do it. And they're anxious to get back to it, even if it's just their evening walk with their spouse. If they're an athlete, they're wanting to get back to their sport. Here are my return to play recommendations for all patients. Post-op and athlete instructions vary a bit, of course, but here they are. Cleared to reintroduce any activity you like, as long as that activity doesn't give you a big increase in pain afterward. Big is defined as enough extra pain afterward that it forces you to do things differently in your day because it's too painful to do them normally. The first sessions back to a new activity should be ridiculously easy, no straining or struggling, using slow movements. Think of the first 2 sessions as a walkthrough of that thing. This finds you a safe re-entry point back into that activity that you can then add intensity to as your body adapts to it. Then we discuss what a successful return to activity looks like, what it will feel like, what milestones to watch for, and how long they should expect it to take. Typically, our bodies feel and function their best when we give them a regular variety of movement. Regular meaning it's not just once a month. Variety meaning it's not just walking, for example. A regular variety of movement means your body is recently familiar with a particular activity. Therefore, it's more capable of doing that thing safely since it's adapted to that activity over time by getting stronger. Also, it's harder to overdo something that you've been comfortably doing for several months since you've proven your body can handle it over and over. And contrary to online gurus, there are no dangerous exercises, just dangerous doses. And I tell this to my own patients. I've adopted this phrase. I say it over and over again, and so far I've only been proven right, never proven wrong. For example, if you get hurt while exercising, it's not the fault of the exercise itself, but something else. There are 3 main reasons I believe why we get injured during exercise. Onboard problems, for example, when your body isn't capable of doing that thing safely, so you do it unsafely and get hurt, like throwing a ball with a fused elbow joint. Don't ask me why you do that. Technique problems, when you perform an exercise in a less safe way, which can hurt, like gripping a tennis racket too hard, you get tennis elbow. 3. Regimen problems, ramping up too quickly into exercise with no chance to adapt, or inadequate recovery, or overtraining, i.e. a non-runner running a marathon. Now, we get this a lot in the Army as well. I see this very commonly. Just ramping up your exercise, your motivation too quickly. My guidelines for exercise. Pick something you love or that seems fun. Start ridiculously easy for the first 2 sessions. Gradually increase intensity over sessions as tolerated. As long as you don't have a big, huge flare-up, you're doing everything right. There are no dangerous exercises, just dangerous doses. And give yourself a regular variety of movement. The philosophy of lifestyle contributors. There's never just one reason for pain. There are always multiple contributors, and they may contribute in different amounts. Some may be 5% contributors, others 80%, everything in between. My approach posits that if we can identify the biggest contributors and address them first, we'll get a bigger therapeutic payoff than if we focus on smaller ones. I judge the size of contribution by the size of the deficit. For example, if I consider 90 degrees hip flexion to be normal range of motion and my patient has 80 degrees of hip flexion, this 10-degree deficit would be a small-ish contributor. By comparison, a patient with only 45 degrees of hip flexion would have a huge deficit. By this standard, we can rank the possible pain contributors and then choose treatments that address those specific problems. Range of motion deficit might be stretch, tenderness is massage, dehydration would be water. Example of possible lifestyle contributors to pain: dehydration, nutritional deficiencies, sleep deprivation, systemic issues like thyroid or autoimmune or cancer or digestion. work, sport, exercise, technique, for example, posture, sleep positions, athletic skills, etc. Regimen issues like overtraining, deconditioning, balance issues, neurologic issues, stressors including financial, social, family, workplace, mental health, or scheduling issues, not enough time for self-care. This theory of lifestyle contributors to pain holds true even for traumatic injuries where one might presume that the trauma is the sole reason the patient hurts. For example, if a patient fell down the stairs and now their shoulder hurts, it could seem true that the fall down the stairs is the only reason their shoulder hurts, assuming it didn't hurt before the fall. However, what if the patient has poor balance? Could that contribute to the severity of the injury of the fall? If the patient had better balance, could that have prevented the fall entirely? Perhaps. What if that same patient had only 3 hours of sleep over the past week? Could the lack of mental acuity or alertness influence their injury in any way? How about their flexibility? If one is falling, could inflexibility affect their ability to fall safely? One patient of mine, an elite ultra runner, told me that he kept having random recurring injuries in different areas and he couldn't figure out what was causing them. As we talked, I asked him about his diet. He's vegan. We calculated that he was getting 20 grams of protein per day, which is nowhere near what he needs for his size, not to mention his heavy training schedule. I bumped him up to 130 grams per day, and his pains magically disappeared. Some lifestyle contributors can actually be the number one reason someone is hurting, and any therapy we throw at them is just going to bounce off and have no effect unless we address the biggest problem first. The idea that posture issues could contribute to pain is roundly ridiculed and scorned by much of the MSK world. The reason? Literature on the topic sees no link between posture and pain. I define posture simply as body position. And while I agree that bad posture isn't dangerous, you're never going to break a bone because of slouching, I see it as a common contributor to conditions we see in practice all the time, particularly the neck, shoulder, and upper back. We all know from personal experience that our body doesn't like to stay in the same position very long. This is why we fidget when sitting, roll over in bed, or stretch when enduring a long lecture. Why do we move? Just to get more comfortable. We've also found that some body positions are more comfortable than others, so we adopt these positions more than others that are less comfortable. Again, it's about comfort. In fact, when prisoners are restrained in stress positions, the civilized world considers this to be torture. Stress positions are simply body positions, but they can be immensely painful. For example, being forced to stand on the balls of your feet while squatting with thighs parallel creates intense pressure, leading to muscle pain and eventually failure. Many of these stress positions are fairly tolerable for short periods of time, but when forced to hold them for long periods, the pain can be unbearable. Does this mean the prisoner has sustained an injury? Not at all. It's just an example of how harmless, quote, harmless body positions, postures can cause pain. Similarly, I believe that slouching, while not dangerous, can contribute to upper back, neck, and shoulder pain over time, whether by overuse of those muscles or simply due to the discomfort of staying in one position too long. And if changing positions gives relief from this discomfort, then we have helped our patient reduce their pain by improving their posture. In short, whatever body position feels best is best. While there are too many possible lifestyle contributors to name here, most MSK practitioners should have no trouble identifying the big ones. Because they're big, they stand out, and they're easy to spot. Like all contributors to pain, lifestyle factors vary from person to person, and their importance can range from insignificant to massive. Identifying them and addressing them effectively is worth the extra detective work it may require. In conclusion, the human body is a complex system. Trying to make sense of it can be daunting, but there's so much we don't know and so many variables to take into account that it's hard to arrive at any strong conclusions about why pain happens, why it gets better, and how to keep it from coming back. I believe this is why research struggles with MSK conditions. Since the causes of pain are so numerous and murky and vary from person to person, a multimodal approach is required. And as a non-researcher, it seems to me the more variables you incorporate into a study, the harder it is to parse out the effect of any one of them. Eliminating the influence of contextual effects alone seems to be a huge challenge. And the larger the study, the less representative it may be to the actual patient sitting in front of you. This information gap between research and clinical practice is what my approach attempts to fill, not by solving any of these mysteries necessarily, but by zooming out and taking a long view of systems rather than cells. Meaning, if we can develop a working understanding of how systems work and what they require to function well, perhaps we can give the body the environment it needs to recover. Zooming in too far seems like it could get us lost in the weeds, forcing us to make more assumptions, ultimately leading us off course. What if supplying our body's basic needs is most of what we need to do? If true, this could simplify our approach to MSK problems significantly and boost patient outcomes. David Poulter, I think I'm pronouncing his name correctly, a physical therapist, puts it beautifully. Therapy in a nutshell. If it moves, make sure it's moving. If it is meant to bear load, make sure it's load bearing. If it's not meant to move, make sure it's not moving. If it's meant to be strong, make sure it is, or strengthen it. Voila. That's from a tweet he made on April 28, 2022. This approach is relatively easy to follow, and it also passes the common sense test. Moving parts should move, and so on. And if following this approach consistently gets the results we and our patients want and gets them faster than another approach, this is what I'll use until I find something that works better. I'll conclude by saying that while I have strong beliefs in this approach, I hold them loosely. I'm always willing to change my position when confronted with better information. My hope is that this approach can be improved upon by bigger brains than mine, and we can advance our understanding of MSK care collectively. To that end, I welcome every criticism and question. This is how we refine our craft, and our patients will benefit. And that's the end of his white paper, 23 pages, and his life's work. I'm going to conclude that right here. Thanks for watching and or listening, and I'm looking forward to